Hello, everyone. Thank you so much. We're just making sure we're ready here. We're very excited to talk to you about the philosophy and components of simulation. Our plan for today is to begin the conversation, and somewhere in between there's going to be a lunch break. We're going to continue moving forward with our presentation, and then when it's time for lunch we'll take that break and then continue on from where we leave after this first section. Are we ready? Okay, great. So our agenda today is to really focus on a couple of outcomes for this two-part discussion. We really want to help define healthcare simulation principles, explore simulation methodologies, which aligns a lot with our conversation yesterday about getting beyond mannequin-based and other methodologies, and really discussing the design of hospital-based simulation at different types of centers. So that's our goal for today. I'm going to see if this works. Okay, so we're going to start with simulation philosophy and standards, and Emma and I are going to tag team this presentation today. And so what we wanted to start with was just exploring having a shared vision and philosophy for simulation. And some of the things that I do in the program that I run is really welcoming the group, but also talking about what is my philosophy of simulation, and thinking about are we there to learn and discover and explore together, and is this really about creating a safe space for learning versus, thinking about, are we there to evaluate practice? So we're really focused on supporting the idea that we are there to think about what we want to do, then talk about what we want to do, and then go in there and practice it. So that's something that we're focused on there. You want to do this section? Okay.
I also wanted to say that one of the most important parts of a shared mental model, so when you're all in simulation together or you're becoming a learner in simulation, is that the healthcare field has some of the highest levels of education of any profession. And yet when you graduate and you move on and you have a job, the learning does not stop. And so when we talk about participants, we talk about lifelong learners. Mm-hmm. And I think the other piece there is deliberate practice. Mm-hmm. So when we go and do, today is Tuesday. Everyone in the hospital is just going in to do their Tuesday work. But I always like to talk about when we're in simulation, we have a chance to pause and think and go back to that lifelong learning mental model, so that when we go back into practice, we can say, okay, let's reevaluate how you're approaching your everyday Tuesday and see how we can both better support patient outcomes, but also the team in making sure that everyone feels part of that kind of lifelong learning culture. So simulation is a technique, but it also is a philosophy. Mm-hmm.
So to give you a little history and go back to where all this started and why we are so committed to this way of learning and being. It was influenced by the aviation, aerospace, power, shipping, military, and the advances in computer science and bioengineering. So it's interesting, like 20 years ago, my first day, being part of the simulation team, what's happened in the change in technology, but even here at BDMS, looking at the change in technology, the change in facilities, how we've leveraged and learned from a lot of other industries to make simulation a priority to keep our patients safe and our workforce prepared. So before that, we really focused in developing our competence and proficiency and expertise in healthcare by practicing on real patients. And there are times when that is, a valuable way to go forward, but I think there's also, it's important to make sure that we're thoughtful about things that we should be practicing in a safe environment where we don't do harm to the patients. To Emma's point about simulation being a technique and a strategy, the important thing is that we're choosing to achieve identified teaching and learning outcomes. And Stephanie talked about that a little bit before, that will guide the type of learning that we're going to do in this environment. And so our obligation to do no harm and really to improve comfort, confidence, and that commitment to lifelong learning we've been talking about. So, the what and why of healthcare simulation. There are a lot of frameworks and a lot of standards that we use to kind of guide us forward. And so one of the things that we look at is simulation has 4 main purposes when it comes to healthcare and facilitating patient safety and quality care. And so education, assessment, research, and health systems integration. And so what you've seen from our team so far is we have really been trying to contribute to the research with the acceptance of our latest article. Thank you so much, Jessica, for keeping us going with that. Education, even for you, consulting and supporting the advancement of medical education in this area, OHSU does a lot of that with as an academic facility. Assessment and also system integration. We've done a lot with system integration and simulation at OHSU, testing systems and figuring out how to continue to improve care delivery.
Do you want to just briefly mention the difference between assessment and health systems integration in the hospital-based simulation? What that would look like?
Go ahead.
Okay. In terms of assessment, so we're going to take a look at how someone is doing a specific task or how a group is working together. When we talk about health systems integration, I think about the new building that's being built at OHSU. We have lots of different towers. There's a new one going up. And so one of the joys in the past 10 years that I've worked in simulation, not just at OHSU, but at other places in the country, is that sometimes they give you a whole new brand ED to play with for 2 weeks. So while simulation can help a new team or a new cohort get used to a new space, and so you get to test the real kind of health systems and what does it look like to be practicing in this brand new space, instead of doing it when you already have patients involved and everybody's there already. Because so much of the work that happens in healthcare is physical. So much of it is where are the supplies, where's the bed, where's the patient, where's the blood. And when you work in new spaces and you're orienting one new person and everyone else is used to it, that's one thing. But when you're orienting 100 new people to a new space, we love to be able to utilize simulation and get in ahead of time. And that's when you can really think about big picture in terms of how do we test a system and not necessarily the people in that system.
And so when we do that in our new building that we had a couple of years ago for the ambulatory area, it's nice to have the subject matter experts, the people who are going to use the space, not just the people who are designing the space, which are 2 different expertise, come together intentionally and really watch someone have to walk from over here to get something to over here in an emergency situation. And even in routine, when you're having to do repetitive motions in care delivery, how those things can be learned by your engineers and your building managers and your designers to make those changes and those efficiencies ahead of time as you're looking at new facilities. So the system integration can be structural, to Emma's point about buildings, but it also can be integration of software and technology to really improve workflow. So those are other things that we have included in that integration. Okay, so the thing that I also want to talk about with simulation that we were kind of exploring yesterday was all the things that you can kind of think about when you're imagining how you can use simulation in your healthcare environment. So we're looking at professional practice. A lot of the people that we're training have some type of professional obligation or role or some kind of license or certification. Interprofessional education, that's really where we focused our energy with all of you in this partnership, has been interprofessional education. But what I'm hearing from our discussion yesterday was you're starting to see different professional groups emerge whether it's PT or pharmacy or rehab and nurses, from the training that they got here in interprofessional education, these professional groups are starting to emerge on their own and focusing on what are their professional needs. So the practicing the thinking, you heard Stephanie talk about that earlier. We've got to practice that thinking, and we had a lot of conversations yesterday about when do you do the information and knowledge piece, and when do you do the practicing, the actual real life simulated practice environment. And right now what we're finding is we need more of both, because that gap is widening. So in your program, you have to think about how much energy and effort do we need to put about information and knowledge, fundamental foundation and thinking in a simulation. What kind of sim would that be? And when we talk about modalities, we can talk about ways to do that beyond lecture, right? How do we do that in an adult learning theory where it's more fun and exciting and it'll stick a little better, right? The other things are knowledge and action, clinical skill integration. I think sometimes we do a lot of separation in the ideas of simulation, vision, and philosophy and standards between clinical skill integration and high fidelity mannequin. And for me, they're both essentially valuable to the healthcare simulation program environment, right? You have to have skill integration, not just a checklist, right? Skill integration is beyond the way we used to do skills before. And the concepts and standards of simulation can elevate our clinical skill integration efforts to make sure that they do have the thinking, they do have the fine motor skills and the steps, but they also know how to communicate, right? So that the skill integration becomes more than just doing the checklist and saying you're competent, because that hasn't really worked out very well for us in practice. So thinking about what is the difference between a technical skills class and a vision towards clinical skill integration as that being the outcome, using simulation as a model to really get to those skills.
I actually have a great example of this that we are transitioning a program into right now. So our second and third year medical students get a very short 2-week elective in POCUS and point of care ultrasound, which is really good. And, but what they were doing was they were just learning how to do it. Mm-hmm. And so they were getting kind of drilled on how to do it and different types. So Monday would be the heart, and Tuesday would be the lungs, and Thursday would be your feet. And so what's happened since is that our head of POCUS came to us and said, hey, we need to work on when to do it, not just how to do it.
Decision making needs to be part of clinical skill integration.
Yes. So they realized that 2 weeks is not quite long enough. So in the 4th year of med school at OHSU, there's an 8-week course for folks who probably will go into that in the future. And so what they've decided is to make the 2-week course a 3-week course, and they've added this more diagnostic clinical decision-making process to the process, to this 3-week course. So the first 2 weeks are still how do we do it, because they don't know. Mm-hmm. So they need to get that skill acquisition. But then the 3rd week is when to do it. And we're pushing the faculty to also include communication back to the SP on why they did it. So in a way that the SP can understand. Mm-hmm. It's a little bit of a stretch because some of them are just into their 2nd year. So, but we're pushing them to kind of say, okay, look at this holistically. Mm-hmm. And then when we think about the patient experience, we also then say, hey, have these learners done draping yet? Mm-hmm. Do they know how to interact with a female patient and the cardio ultrasound? Do they know how to physically maneuver the sheets? And do they know how to ask questions about that? And so what became started with this very isolated skill set, which is needed, mm-hmm. and the foundation for what we're doing, has turned into this kind of larger process about deliberate practice and also how they're going to integrate this curriculum into the larger scope of healthcare service. So that's kind of, I think, a
Lovely example.
pertinent example.
Yep. Because it leads into, what we would talk about before is just doing a STEM on a protocol or procedure. Yes, you need to do those steps, but a lot of times we end there with our clinical skills courses or events. And we're not thinking about what we've learned from other industries. Like, pilots don't just do that when they do aviation. They have decision making in there too. Those are integrated concepts. So we need to move beyond like how we used to do it before we knew about SIM and just the steps, and think about all these other things that could be integrated into one simulation, whether it's a skill or mannequin-based, those types of things. So the decision-making pieces are usually included in a lot of our events because it's important. It is did I lose it? No, spiraled in there so that they make sure that they have the little steps, but then what's the next thing you spiral in? It doesn't just end, and it's that lifelong learning, and it's ongoing in their practice because they're professionals. So communication, teamwork, thinking about what are high risk, low volume, and remembering the routine also needs to be considered. Sometimes we're not really good at routine things or identifying what the problems are in our routine practice that we need to consider. Work intensity. So we're seeing a lot of evidence and a lot of information coming out about ways to measure work intensity. We talked a little bit about this yesterday. When you're on the units with your staff, frontline leaders, or you're out there practicing, post-pandemic, we have a new sense of work intensity. And we're trying to understand how does that impact people's well-being, we talked about that, and how does it impact their care delivery to meet patient outcomes. And so we're looking at actual tools to measure work intensity. Workflow, to the point that Emma made before about health system integration and assessment. Sometimes the workflow gets in the way of good practice. Pace, and then variation of patient stability and acuity. What are your KPIs? So these are things that we wanted to expand on during our visit here to be considering about what and why healthcare simulation is valuable. Some last thoughts are making mistakes. It's a place to make mistakes and do no harm, as we talked about before. The individualization of the level of the participant, we can modify like we talked about yesterday. You can use the same scenario, right? Same outcome, but you're individualizing to role or level of participant, right? It's the design that we're altering, not the outcome.
Yeah, and I do want to just mention, because we talk a lot about do no harm in SIM, and reflecting on the conversation that some of us had yesterday about mental health and simulation and our staff, what we've come to find out is that the do no harm really just relates to patient populations in simulation. So when you have staff and when you have SPs involved, standardized patients, and when you have learners and faculty, there is an opportunity there for, or a risk there for a little bit of harm to happen, or a lot of bit of harm to happen. So when we talked about yesterday the possibility of re-traumatizing folks who've had similar incidents in their past, or new incidents that they didn't know about. I'd like to talk about it more now, like the reducing harm, or the least amount of harm as possible. Because when we're in simulation in any learning environment, especially an active learning environment where we're maybe doing team-based work, we like to say that it stays there, and it mostly does, but sometimes it doesn't. So these teams work with each other day in and day out, and some of those same teams and those same formats come to the Sim Center. And most things stay, and some things trickle out. And so it's important as SIMFA, it's important as a center to understand the impact that you're having, even if you're not taking care of a real patient. We should say, no one's dying here today. And that's true, hopefully, very true. But it doesn't mean that there's no harm and we don't have to think about it. So we need a little bit of intentionality in the way in which we go about doing things, or a lot of it, so that we aren't the people who are causing harm to the learners just because there's no patients there, or ourselves, or the SPs.
Absolutely. Okay, I'm going to move on to the next idea. So we were talking about this before. What are the methodologies we can use in healthcare-based simulation? And I think we're at a point now where we're seeing all the different ways, 20 years in, that we can apply this strategy and this philosophy to everything we do in healthcare. So we're seeing a lot more during the pandemic, a little bit less now on computer-based simulation. It's very valuable to have. There's really nice options, and it does have its limitations, right? And I think people are a little overloaded with that at this point in their education and learning, and are really looking for more interaction with each other. But it's a really nice option to have. E-learning is another option. We're really leveraging e-learning for that information, knowledge, and foundational, fundamental briefing type or pre-briefing type of work, and we're finding that there's a lot of value in that, and the independence and self-directivity that offers has been appreciated, particularly by this next generation of healthcare professionals who really like access to things and things to be fast and not to have to come in if they don't have to, really an efficient, effective way to deliver information. We've been doing a lot more gamification as a way to deliver new information, or really trying to get creative with a specific content. So I'm not sure if you're familiar with the idea of an escape room. What that is, like an escape room. I'm not sure if it translates as well, but we've created a simulation escape room event, and it's been very popular, and there's an outcome, and they all have to work together as a team to like escape the room and do these puzzles and these games, but it's really about the outcome, and that form of simulation has been well received by a lot of our teams who are usually typically cynical, like OR, usually. Any OR people in here? So the OR team has really, really enjoyed that being one of the ways we deliver their sim content is through gamification and an escape room. The hybrid model has really taken hold in being able to do different types of mixes of role play or e-learning with high fidelity, or skill integration with high fidelity, a bunch of different things. You want to do the next ones?
Insight 2, we're familiar with here, but that's going to be doing simulation in the place that is practiced, so in the clinical space. And we'll talk about fidelity in a little bit, but it's one of the best ways for folks to get buy-in, so that you're saying, yes, I'm working in the space, I'm practicing in the space that I'm currently in. Mannequin, so that is one of the kind of bread and butter methodologies in simulation. It's what a lot of folks do here, and it's going to be kind of more of your, well, you have low, mid, and high fidelity, so we work on different types of mannequins. Role play is going to be when you really need to start with your novice learners and just say, okay, talk to this person because you need to figure out how to talk to a patient. Just get started. Just start thinking about the questions you're going to ask as a clinician or as a new clinician. Standardized patient is going to be for when you need that communication piece, or you need to explain something to somebody, whether that's a patient or a family member. Task trainers are, again, the very specific kind of skill acquisition. So you need to do a Foley cath, or you need to do suturing, or you need to do something really specific. Tissue-based is going to be, you need to do something specific, but with tissue. And then unfolding case studies are tabletop studies. Yep. So these can be, I always say simulation can be with no electricity, 3 people in a room with and a meeting space. So you can walk through and talk through a potential case. And one of the great things about unfolding case studies is that they can be recent, they can be from yesterday, or they can be made up and kind of used to illustrate a specific point. And
so,
yeah.
And so what we want to just highlight with this is just that you have all of these different methodologies in healthcare simulation, but you're using the same framework, you have the same vision and philosophy and the same standards in the way that you structure the design, and we're going to get into that a little bit more later, but just kind of thinking that you can do that for all of these different ways that you're delivering your content. Okay.